we have invited Dr. Castro to be our source person. Dr. Castro is a graduate of UARM College of Medicine. He is an internist and a cardiologist and also an intensive care specialist. So let's give the time now to Rod. Dr. Castro, thank you.
Hi, sir. Good morning. Good morning, everyone.
Morning.
Yeah, thank you so much for inviting me again, no, for to discuss this topic. No, very seldom actually that this topic will be discussed in med school. So I actually I tried actually to teach our fellows, no, our residents also on how to handle medical conferences or family conference, and they they didn't really recall that they have one no during their med school. So I'll be sharing my slides. Okay, can you see now my
Okay.
slide?
Yes, we can see
Okay,
it
po.
now.
So let's start. The objective of this session actually or lecture is at the end of the session actually you will be able to gain um, knowledge of the following, no? Definition and purpose of advanced directives, barriers and solution, no? In implementing advanced directives, and of course, the benefits, key functions. Wait lang, sir. Parang, that's not the, wait lang po. Sorry.
Okay.
Wait lang, sir. Hmm, wala. Oh, yeah. There you are. Can you see
Yes.
the slides po? Sorry.
Mhm.
Iba po yung
Ibang
nag-focus.
version.
Ibang version, yes, sir.
Ah,
Yeah.
okay.
Again, of course, I'd like to start off with the case. Now, so here we have a 47-year-old female newly diagnosed with stage 4 breast cancer, metastasizing actually on the brain and on the liver. Came in because of difficulty of breathing. Upon arrival at the emergency department, this patient had vital signs were as follows. Now, 80 over 40, heart rate of 120, your respiratory rate 28, and the saturations at room air is 78%. Upon working up, no, the significant finding, one of the significant findings is having a massive pleural effusion on both lungs on chest ultrasound. And upon having the blood gas, getting the blood gas, oxygen saturation was very low at 67% at 10 liters per minute of oxygen support. However, this patient had expressed before for advanced directives not to do any heroic measures like doing CPR or cardiopulmonary resuscitation, having her intubated, and that was actually written in her living will. During that time that this patient have to do such measures, the husband wanting actually to override the decision of the patient, and the husband in because of his desperation he talked to the doctor, no, not to honor the wife's wishes. Question is this possible? So let's talk about advanced directives. Advanced directives are documents a person completes while still in possession of decisional capacity to really ensure their values are reflected when considering how treatment decisions should be made on their behalf in the event that they lose the capacity to make such decisions. These are legal tools directing treatment decision making and or appointing surrogate decision makers or proxy. These advanced directives will give you preference for life sustaining therapy, which might change over time. This advanced directive should periodically be revisited. So, meaning doesn't necessarily mean that if you've signed your advanced directives now, but your condition is starting to improve, it doesn't mean that you cannot really revoke that. No, as mentioned here, these advanced directives can be revoked orally or in writing by the patient at any time. So it cannot be revoked, no, by anyone except by the patient only. No, not the just like in our case, upon with his desperation, the husband would want to withhold or revoke or override the decision of the patient. Now, but in this case, as mentioned here, you cannot do that. Only the patient has the right to revoke that advance directives, either orally or in writing, so long as this patient has the capacity to make the sound decision. Okay, so advanced directives is governed by the ethical principle of autonomy. Now, meaning it's the right of the patient to make that decision to choose whatever treatment either he or she would want to undergo the treatment or not. No, as long as she is in sound mind and can make that decision for himself, he can have signed that advanced directives. The patient formally specifies the care preferences during periods of incapacity and at the end of life, having that living will, assigning proxy to make healthcare decisions, of course, with the power, no, of attorney at in place. So these advanced directives are very useful for specific clinical situations in which it can be applied. It is important to note that the ill patients may change the preferences for or against life sustaining treatments as their condition worsens. Here, once these advanced directives are facilitated, the successful advanced directive can be easily started or initiated. Now, and of course involving now the patient or the proxy of the patient now can make this uh, paper or advanced directives successful. In our institution, here is the example of this form. As you can see here, it's very specific. Either the patient's family will going to hold or continue no the life support of your patient. As you can see there, if you were gonna do CPR, intubations, intravenous fluid, so any life support for that matter. And also, if DNR is in place and you want it to be done, you can also you don't want it to be done, you can sign this form, and this is from our legal department. So this is what you're going to see once you will rotate in the medical ward or in the hospital side. What are the barriers in completing advanced directives? There are actually physician related and patients related. So for the physician related, some physicians are not comfortable with the topic. In other country, that lack of reimbursement and lack of institutional support can be a factor, no, wherein you cannot complete the advanced directives. In our setting, most of the time we don't have time, no, lack of time really sitting down, talking to the family, talking to the patient, or at times we have we wait for the patient to initiate the discussion. Now, especially as I mentioned, if these physicians are not comfortable in discussing this topic, now of course you cannot really wait the doctor to talk about that. No, how about patient-related factors or barriers? The fear of burdening family or friends. No, inisip nila kasi pag sinabi mo sa family member mo, parang responsibility na ni family member, no, to take care of the patient. Health literacy. No, sometimes they don't want to talk about that. No, they don't want actually to dig further about the content ng advanced directives. Of course, here some because of our cultural orientation, no, we don't want to talk about that. Kasi we always think that once we start to talk about these things, no, it's like a premonition that something might happen to us. No, but it's not. That's not true. And spiritual, cultural, and racial traditions. And here also, waiting for the physician to initiate the discussion. So, ito nag-aantayan na. How are we going to address that then? Now, here are some solutions that we might use. No? We have to, in terms of the terminology, pag sinabi nating toxic or benign, no? We have to, ayan, terminal and no hope of recovery. We have to really identify and clarify what does it mean when we tell them that your family, your mom is already in terminal, or there's no hope really that your mom is going to recover. So we have to expound those things not to the family. We also have to clarify what's the meaning of life support, and when we say there's no heroic measures, no, and indicate wishes regarding specific scenarios and interventions. Have ongoing conversations with the patient. So always involve and explain to them, and always ask at the end of the conversation, did you understand about our meeting, or did you get that whatever um, updates your doctor gave you? You have to ask, no, the team or the family or the patient to, if they understand the situation. Early on, as I mentioned, you have to include proxy, because if the patient will go on coma and he can no longer make that decision for himself, at least someone, no, has to be responsible in discussing about the situation of the patient. So include also advanced directives in the medical record at the office and hospital, and be sure to transfer with the patient to other levels of care. This is very important because, as I gave this example also yesterday about a patient, a very prominent patient, wherein this patient underwent um, valve surgery, heart surgery, no, and of course, um, they he she the patient is a female. She wanted to undergo, yeah, she wanted to have the procedure and um make really her luck, no, to be successful in the operation. And however, she did sign the advanced directives not to do re-intubation, not to do CPR or cardiopulmonary resuscitation, and no defibrillators. We all know that post-heart surgery, actually, this patient has high risk in developing arrhythmia or electrical conduction problem. True enough, no, when she was in the recovery room under my care, no, glaringly, this patient developed ventricular tachycardia, no, pulses ventricular tachycardia, and supposedly I have to do defibrillators. It's good thing actually that when I first see the patient, I have to look at the DNR, no, the form which she signed herself, no, a night before the OR. Then when that thing happened, all of her children, no, came to me, and they wanting really to um, revoke that and override the wishes of their mom. But yeah, unfortunately, I told them it is my legal obligation to really honor whatever that is written in the advance directives made by their mom. No, so I have to get hold of that, and you have to know that kasi kung hindi, nako, there will be some repercussions or consequences when you override their wishes. No, kasi pwede tayong mademanda. Okay? So, uh, these are suggested approach to include advanced directives in the primary care. As I mentioned, because of our culture, very difficult to discuss this in advance while the patient is still strong, while the patient can still work. You know? So here is some of the stages that you can actually make a discussion point with your patient to address these directives. When your patient will go to you and they are under 50 to 65 years of age, you can actually start to discuss about advanced directives. If you were, these are some of the discussion points. Now, if you were get very sick, who would you trust to make medical decisions for you? Have you thought of completing an advanced directive? How would you like to be cared for if you had a devastating injury or illness? So just show them the content of the advanced directives. They don't need actually to answer right there and then. They, in fact, they can bring the form at home, and once you ask them to have their next follow up, you can discuss that if they're more comfortable na. Basta do not force them. Now, if they don't want to talk about that, just try really to incorporate that advanced directives during their follow up by following some of these discussion points as suggested. Next, after a routine visit, here comes now, once the patient has been diagnosed with progressive chronic disease like heart failure, cancer, dementia, or COPD. These are some of the discussion points that you might want to try in starting the conversation. So, like for example, you will tell the patient your health has changed. What is your understanding of your condition? Do you have any feelings about what you have experienced so far? Have your goals for care changed? Have you discussed your feelings with your loved ones? Offer to meet with patient, proxy, and family members. No, discuss how changes in health may have changed advanced directive goals and updated form or update forms. Next, last stage actually is once the patient has increasing frailty and dependency, meaning this patient already are admitted in our institution because of chronic problem. No, on the second stage, kasi they've been diagnosed with progressive chronic disease, and here comes now the increasing frailty. So if the patient on the second stage doesn't want to discuss about the advanced directives, maybe when that time comes that there will be increasing frailty, they might opt now to discuss with you about these things. Discussion points like if times become short, what is most important to you? Have you spoken to your proxy about any changes in your care goals? So, in other words, you're trying really to initiate this type of discussion. At least at some point, you will know that this patient will end up quote unquote comatose or GCS3, or they cannot make that decision. So, at least at the onset, you have planned already in terms of discussing the advanced directives. Family conference. So we have two cases actually for this as an example. Uh, we have a 41-year-old male. There are no known comorbidities. He is a practicing plastic surgeon. Had a motorcycle accident. No, and however, because of the big impact during the accident, your physical examination patient turned to become GCS3. And upon doing CT scan or imaging, the brain already is herniated. Of course, because of the suddenness or acuteness of the problem, the family would want to do everything to save the patient. What will you do? On the other hand, you have a 94-year-old male. He's non-hypertensive diabetic, bedridden because of multiple strokes, admitted because of pneumonia. Sometimes this is very common in our local setting, wherein a lot of children are living abroad, and very few really that there are children also staying here in the Philippines taking care of their ill patients or ill parents. So the family in the US wants the patient rather to be DNI or DNR. However, the children here in the Philippines would express their desire to do everything for their dad because they've been seeing their dad, and of course they would want um, to do everything certainly because this family members are always with the patient. So, as a doctor, what will you do? So let's start about family conference. Having a clear, effective communication among patients, families, and healthcare teams enhances patient care and patient satisfaction, which correlate with physician competency in communication. When family conference is held proactively, family meetings have been shown to reduce time in the intensive care units, allowing now for earlier withdrawal of advanced support without increasing mortality rates, and allow for dying patients to access palliative care earlier, since you will be discussing these things to the family via a family conference. The key functions of a family meeting: it builds rapport with the family, it offers support, whatever kind of support, maybe emotional, no, psychological support, things like that. Provides updates about the patient's medical status. This is a very important function of a family meeting. At least all of the care team will be there discussing every specialty that the patient has been referred to. Very important also that during the family meeting, the family members would ask for the prognosis, and this is the venue actually that we can talk about prognosis. Ensure that the treatments are consistent with what the patient wants. Now, what are the benefits of a family meeting? It prepares the family for likely outcomes, whether good or bad, provides the family with information they need to make informed decisions, increases family satisfaction with care, and it actually improves psychological outcomes. Potential challenges, though, we know that families come with history. Now, we don't know really the dynamics of the family. Family members play roles based on position in the family, relationship to the patient who is ill, special talents, etc. In our culture, sometimes the decision maker are the financer also. So that can make sense since here in the Philippines, especially if the patient is admitted in a private institution where cost is very variable and very important aspect, in our society. So that can make a lot of difference and a potential challenge also. And a narrow focus can help alleviate some of the pitfalls, actually, some misbeliefs of the family members, yung mga marites sa mga kapitbahay or family. Remember that the task of the family conference is not to fix, quote unquote, the family, but rather have everyone on the same boat as much as possible in caring for the patient who is ill. Your main goal really disregard about the dynamics of the family. Sometimes kasi, like for example, like in my case now, I usually um man the intensive care unit of our of one of the institutions now here in Metro Manila. Sometimes the patient has is with her her legal wife, no, or her partner, and of course once the children would come in, no, and they don't know the that living partner of the patient. Now there's some big problem actually that you might encounter with that. That's why you have to know. But as mentioned here, it's not your goal to fix them, but rather if you can gather them aiming for one goal really with the ill relative or ill patient. Okay. For the win-win situations, you have to do consensus building, accept approximations of a good solution, make agreements on a time limited basis to see if the agreed upon action will work. No, so after talking to the patient about what's happening, and you know for a fact that this patient is deteriorating, so you can actually tell them no about these things. Schedule future meetings to evaluate trials and do revisions as necessary. Yeah, this is very important because after meeting with them and things might change. No, probably if something happened just like what happened lately now to me, we're supposed to have a patient who has ovarian mass. No, we're supposed to do biopsy the following day. No, we had the meeting during the night, so all things are already set. Now however, at around we had the meeting at 7 to 8. Now when we finished the meeting and everything has already been set. However, this patient developed stroke around 8:30 in the evening. So change happened again. And it's a responsibility of the attending physician to call again the family for the sudden change of plans. Now, that's a very important one. And make that consensus arrangement again. Compromise, it's sometimes this is where compromise is has benefit. Now, you have to be open to alternatives. Think about how each person should be acknowledged during the family conference. And very important aspect in doing family conference is putting all the agreed decisions to put it into writing. Then you have to distribute calendar with different days, mark with responsibilities and commitments to help each person honor the agreements made. So it's just a reminder later on that you can tell to the family, we have agreed before that according to Mr. Ganito, he said during the family meeting that he doesn't want to have a, a very aggressive form of support, etc. So you can just easily retrieve that if someone is writing the meet or putting notes now in the meeting. So how to have a family meeting? One, you have to prepare. Majority of the preparation is to identify and discuss the agenda items now with the care team. Agenda like latest report from the physician, sharing of feelings about the illness or the caregiving, agenda about yeah, having those kind of feelings, the fears, now the death and dying, being overwhelmed of all of these things, especially me as a cardiologist, we many times we encounter this type of situation because if the patient um, had chest pain and eventually diagnosed with heart attack, and the heart attack is massive. So imagine that, for example, you just had dinner with your loved ones a night before the event happened. So imagine how are these people are overwhelmed about what happened, no? Because of the sudden death or the sudden um, toxicity of their loved ones. So also dealing with sadness, confusion, no, anger, guilt and shame. What does the ill person would want and would need? Now, talking about this thing in the preparation, and of course the daily caregiving needs. And this comprises actually should the ill person move in with family members? What would be the setup now? Does the ill person need to be an assisted living facility, or shall we just bring the patient to a nursing home? How much time does each family members have to visit? What are the other ways each person can help? Now, things like this to address the daily caregiving needs. How about the financial concerns? Again, this is a very important factor. In fact, this is an independent factor now in handling our situation, especially here in the Philippines. How much work can family members afford to miss, especially if they would really want to see and take care of their loved ones here in the hospital? What financial help might be available outside? So, just like again, sorry if I keep on putting up examples now because here in my practice, as mentioned by Dr. Chua, I am a critical care specialist. So I see almost every day, holding family meetings, discussing about the condition of the patient inside the ICU, etc. And majority of the time, these financial concerns really can make an impact in the management, even if we don't want actually to be concerned about in this matter. But of course, this can lead you or to the direction that you're wanting to have. Just like yesterday, I have a patient in the other hospital wherein he's been there for almost 3 months. And we had a very difficult case. We have a redo, meaning we subjected the patient to a bypass surgery, heart surgery. Aside from the coronary arteries, we also changed the valve. No, so the mitral valve. So this patient actually stayed in the hospital for a long period of time. Actually, until now, he's still in the hospital. So the family came to me yesterday and they asked me, Doctor, this is our bill, and their bill is already 7 million, now 7 million already. And they've been expressing to me that they don't know where else to find help in terms of the finances. And of course, they open to me what will happen if they will bring the patient home. He's not yet ready because this patient is on trach mask, and we're still in the process of rehabilitation. So things like that, no. And that financial concerns, as I mentioned, is an independent factor because in as much as they want to continue with the management, with the support, but if they don't have the means, no. So you as the primary physician, you have to really help the family also to find ways on how to help them. Me, what I offered to them yesterday to transfer this patient here in our institution, because definitely it's a lot cheaper, no, than where they came from, no, in the hospital. So again, this is a very important um, thing to consider about the finances. Another agenda that you might want to uh, prepare, no, during your meeting, you will have to ask who will make the decision, the financial, the medical decisions, hiring a caregiver, how will they be made, no. Other agenda, what sort of support does the primary caregiver need? Of course, it's not only the patient needs that you have to be concerned about. Also, you have to take care also of the needs of the primary caregiver. And here are some of her or his needs, no, about the caregiver. Another things that you need to do and prepare, how the caregiving and support needs change as the illness progresses. And of course, you have to list of tasks to be done to solve this kind of problems. How are we going to facilitate that? And importantly, you have to make summary of the meeting and schedule for the next meeting. So these are the things really that you need to do. So aside from this setting up the agenda, also part of the preparation is to review the clinical data, location where you would want the family meeting um, to hold. No, very important right now though, the advantage of having Zoom meeting. No, because of the Zoom, the capacity to interact all over the world. Some members of the family who are living abroad, they can now join you in the family meeting through Zoom. Very rampant. Now, these situations are very rampant during the pandemic, and even now, no, we adopted that. So that's one of the good things really the pandemic brought to us, having this type of meeting, just like what you are doing at the moment instead of face to face. Who should attend? Everyone who is or will be part of the caregiving team should be present during the family conference. Sometimes they could also ask some family friend who are living abroad, especially those who are knowledgeable with the health condition, especially doctors. They've been their doctors for quite some time, and they would want to that doctor to be present during the family meeting. So what you can do, the family member would deal that by asking the main attending if it's okay that another doctor from the other institution or a family friend can join them in the meeting, and that's very common. Who would attend? Outside facilitator also to help the family communicate, especially if you would bring your patient to a nursing home. The social worker should be there, and the other members, um, of that um, of that facility now would join you. Note, decision should be made whether or not to include the ill family member in the meeting. This is very difficult situation because many times, the family member the family member don't want really to members that don't want to um, have the ill relative to join them. But in my case, I always encourage the family member, if the patient, because they know, no, they know the ability of the patient. They know how the patient would cope up with stress, like telling the bad news or telling whatever situation he is in at the moment. Because definitely, as I mentioned, the patient has the right to know. So at least he can make that decision for himself, whether or not they will avail the treatment options that you will be offering them, or you will be offering to the patient. So very important actually that you will um, allow the ill member of the family to be present in the meeting, unless specified by the family members, the other family members, that they don't want. Like for instance, cases like if their parents are very old and they don't want them actually to worry more. So this situation, yes, we can allow that. No, we cannot involve actually the patient who are, or the patient herself who are ill. No, so if they, because the objective naman is directed, no, towards the ill family member. Okay, so step two, introduction and the agenda again. Well, every start of the meeting, you have to make sure that you introduce yourself. Usually, the attending physician would facilitate or will be the moderator. But in the setting wherein you have intensivists in the ICU, usually the intensivist would man the show. No, and of course before that, he will introduce the different members of the medical team. Likewise, now you have to assign a representative now to the family members who will be speaking their behalf. And but just the start of the conversation or the meeting, make sure that you have to introduce everyone present in the meeting. Give everyone chance to be heard. All feelings are appropriate and need to be expressed and acknowledged during the meeting. So even if there will be some shouting, some form of miscommunications during the meeting, just allow them, especially with the family members. No? And when the time will come that you really need to intervene, you being the moderator or the attending physician who is the facilitator would now try to make the family member calm. Now, next, discussion of patient status and prognosis. Elicit the perspectives and views of the family members by uh, ask, tell, ask communication technique. So um, how this work? No, this ask, tell, ask communication. You have to ask family members to describe their understanding. No, sabihin mo what can you understand so far about the present situation of your mom or your dad. Then after that, you have to update them or share the clinical assessment. Now, would be your objective finding with the patient status and the prognosis. Then after that, you have to ask the family members again about understanding of the new information or any new questions or concerns. Then conveying prognosis, this is very difficult, but you have to be transparent and identify the best case, worst case, and most likely scenarios that you will be having. You have to discuss that. What would be the best case? What would be the worst case? And what would be the most likely situation that you will be in? Remember that you have to use clear, succinct, or concise statements that avoid medical jargon. You have to really make sure that you communicate to them in a manner that it is easily understood. Now, and if you need guys to pause while providing information. Please make sure that you're gonna do that. No, show empathy. This is very important, and try to understand the family member's perspective. Improves family member satisfaction and psychological outcomes. Majority of the legal issues now brought about in the hospitals are the miscommunication between the medical team and the family. Some of the roots of the problem legally is when the family members are not informed, or they're not aware of what's happening to their family, to their ill family member. Then all of a sudden you will just break the news that something happened to the patient, and that can really cost them a lot of trouble, no, a lot of troubles later on, especially in terms of the legal. No, that's a time that they would really scrutinize everything that you do. So that's why at the onset, if you can actually show some empathy when talking to them, understanding the family member, and having time, spending time with them really is very important. Okay. This value 5 step, we use this actually in the ICU. Very important to remember this one. The value, value family statements, acknowledge family emotions, listen to the family. Very important aspect here to consider and to do. Understand the patient as a person. Elicit family questions. So this, we use this especially in the families in the ICU. Now the term value. Clarification of goals. Step 4, discuss patient as person before illness. Now, meaning you ask the family member if they can recall any situation from the past wherein the ill family member would tell them what to do, when this situation will come to play. And sometimes you can elicit that by asking them this question, no? Questions like, nung time ba na nabubuhay pa po si mami, ganyan, sinabi po ba niya sa inyo na gusto niya tong ma-resuscitate o ibobombahin yung kanyang dibdib, things like that. Now, those specific things that you might want to clarify. No, so of course, explore agreements and disagreements between clinicians and the family, and between family members. It's very important here actually that they understand, every step of the way that you are doing in the ICU, because their family members are very ill. Discussion of treatment options. One, you have to summarize families' hopes and worries and the things they identified as important for the patient care. Review options within the defined goals and offer recommendations. Give families time to reflect on the information provided and to talk among themselves before making a major decision. This is a very common problem in the ICU, because some doctors, they would force the family, to make the decisions right there and then. But here, where I'm telling you, you have to give time. Now, after discussing some important points, tell to the family that I will be giving you time to think about this. If you need to consult that to other family members who are not present here, please do so. No. So we have to give them ample time. So the question there is, up to when? No, up to when you're going to give them time. So basically, once the decision hasn't made yet, has been uh, addressed, but no decision yet on what to do, our goal as physicians actually, or our job, is to do these heroic measures. Like if we see that the patient needs intubation and they haven't given yet the advanced directives not to do intubation, our job is to intubate the patient, because they haven't given yet their decision not to do otherwise. Okay, basta give them time. Here, this is a very important concept: shared decision making. Remember that the responsibility for decisions is shared by the health team and the patient's family. Okay? And as I mentioned, you have to make summary and discussion of the next steps. recap areas of agreement and disagreement, review next steps, discuss agenda for the next meeting, ask how information will be communicated to the family members not present at the meeting, and end the meeting by thanking the family and acknowledging that this is often a difficult discussion. Aside from thanking the family, don't forget also you being the attending physician to thank all the members of the care team now who spend their time also talking to the family. And lastly, you have to do debriefing and documentation, review the events, discuss any changes in the care plan, discuss areas for improvement, and document a summary of the meeting in the patient's medical record. Debriefing actually can do this, allows the clinical team to reconcile different perceptions of what occurred during the meeting, to review changes to treatment plan, and provide feedback on what went well or might be done differently next time. So, in summary, advanced directives enable a patient to maintain autonomy and prepares patient during periods of incapacity or at the end of life, involving the patient's family and proxy decision maker early and over time may be the key to successful completion of an advanced directive. Decision making responsibility is shared by the health team and the patient's family. Family conferences, meetings are important communication tools. Value five-step approach helps improve communication with the families. And when conveying prognosis, it is best to present the best case, worst case scenario, and the most likely scenarios. Use clear, succinct statements or concise statements and avoid medical jargon. Acknowledge each family member's feelings and concerns, show empathy, and elicit questions to clarify any concerns or questions. Debrief with care team for reconciliation of ideas and opinions, review changes to treatment feedback, and for further improvement. And I'd like to end also with this verse no, from Hebrews 9 27 28, because our topic actually soon, no, at some point, we will be doing our own, no, our own advanced directives. And remember that we're not a citizen here in earth, no, just remember this verse, just as man is destined to die once, and after that, all of us actually will face judgment. So Christ was sacrificed once to take away the sins of many people, and he will appear a second time, but this time not to bear our sin, but to bring salvation to those who are waiting for him. Okay? Again, thank you for listening. Back to you po, Dr. Chua.
Thank you very much, Rod, for your time and your expertise on the topic. We'll have a few, maybe just 5 minutes for open forum because Dr. Castro has another appointment at 9 o'clock. So you can ask your questions now, class. You can send a direct message to Dr. Castro to the chat or raise your hand and unmute yourself if you want to talk. Go ahead.
You can actually chat your question. You can write that in the chat box. So basically, yeah, hi Doc. Thanks so much. Just want to ask ko for patients who have long-term disease, how often should we renew their advanced directives? Okay, some of the hospitals, they would want the advanced directives to be renewed every day. Okay, every day you have to ask them all over again. But in our practice, since they've been here, they've been in the ICU for quite some time, if there are major changes in the directives, that's the only time that they have to renew and rewrite another thing, no, another document to revise, no, to revise their advanced directives given prior. No, so it's not necessarily that you do that every day anymore. Okay. How about ill patients who don't have close family members? And do proxies have to be a relative? Thank you po. Okay. Technically, anyone could be a proxy so long as there will be a durable power of attorney in place. So even if that patient is not your relative and you are assigning that, since you've established a good relationship for the longest time and you want to assign this patient as your proxy, yes, not necessarily that proxy is a family member or a relative. Okay? How do you manage a family meeting in the case where the dying patient is the breadwinner, head role, and there is no clear leadership bickering among the children or siblings? There's actually this happens a lot, you know, and sometimes once the patient is the breadwinner or the head of the family, that's the time really that all of the family members are very aggressive because they would know the effect. Now, once this loved one will um, will pass away, and he is the breadwinner of the family, very difficult really. You have to really spend more time. This family gathering or family meeting would sometimes require a longer period of acceptance. No, that's why you have to sit down with them, no, because there is some form of in denial, really, no, in denial, and they cannot really accept that. Very difficult, very difficult. So I have one patient, no, last time. Um, she had no advanced directives, no advanced directives. So the patient is a female. The wife, no, the wife actually is a patient, and they've been having a good time, no, in the ICU. And around 9 p.m., the husband, no, asked permission to just go home for a while to take some shower, no, some um, hygiene lang, some cleaning for himself. Then when he was away, that's the time that the patient arrested, no? Yun, nagwala. And very difficult, no, to handle that type of meeting kasi walang advance directives nga. Tapos nangyari yan. And expectedly, that happened. And the patient is the breadwinner, no? The breadwinner of the family. Kaya hirap na hirap nilang tinanggap. Okay? Any more question po? Okay. For example, the patient wants to revoke his or advance directives of DNR, DNI, but is not of sound mind, deciding capacity, or can it still be revoked? Okay. I think that's a very tough question. Again, we have to see the situation first. How come the patient would want to revoke? Even if our judgment call is he's not in his sound or the in a perfect sounding or their deciding capacity, so long as the patient verbalized that either he is in his sound mind or not, no, we have to honor that because in the first place he or she made that decision to do or to sign the advance directives. That at some point, even if you would tell me that she's not in his sound mind or she's not really in his optimum condition, but if you are telling, if the patient is telling you that he or she wants to revoke that, yes, we can still do that. We can still do that. Okay, other question? Wala na, nag-thank you lang pala. Okay. DNR. Okay, any more question po? Wala na po. Just
Okay, wala
type.
na.
Mukhang wala na po, sir.
Okay. So I think we have to end the session now. Thank you very much again, Dr. Castro. And for the rest of the
Thank you, sir.
class, I posted the details about your assignments or the last assignment for the second semester. Just read through that. And if you have questions, just email me your concerns. Okay. Let's end the session today. Let's thank Dr. Castro and
Thank
have a
you.
good day, everyone. God bless.
God bless you. Bye-bye.
Bye-bye.
Thank you po, Doc.
Thank you po.
Thank you po.
Thank you for
Thank
the
you po.